Welcome to the second of 3 national webinars on Mpox. I'm Destiny Kelly, the National Coordinator of the NNPTC. If you are currently having technical difficulties, please reach out to our producer, Kim, in the chat. Today, we'll be hearing from 2 of our clinical faculty, Dr. Nick Van Wagner, Associate Dean, School of Medicine at the University of Alabama, Birmingham, Associate Scientist, Center for AIDS Research, Assistant Professor, Department of Medical Education, Scientist, Center for Clinical and Translational Science, General Clinical Research Center, Associate Professor, Medicine, Infectious Disease, Department of Medicine, and Co-Medical Director of the Southeast PTC. Additionally, we have Dr. Joseph Cheruby, Assistant Professor, Division of Infectious Diseases, Washington University at St. Louis, Director, CDC Track 2B Capacity Building Assistance Program, Associate Medical Director of the St. Louis County Sexual Health Clinic, and Associate Medical Director of the St. Louis STI HIV Prevention Training Center. There will be a few minutes at the end of the webinar for a question and answer session. Please use the Q&A function to ask your question, not the chat function. This webinar will be recorded and you will have access to the recording within a few days. And we are not offering CE for this webinar. The NNPTC is made up of 8 regional prevention training centers known as the PTCs and 2 national centers. We are CDC funded to train clinicians in the diagnosis, treatment, and prevention of STIs. You may recognize the names of our 8 regional PTCs on the right. And as you can see from the map, each PTC has region-specific states that they serve. I will be sharing several products and resources that we offer in the next few slides. The National STD Curriculum is housed at the University of Washington. The National STD Curriculum is an up-to-date website for clinicians and other healthcare professionals to learn about the diagnosis, treatment, and prevention of STIs. There are self-study or quick reference lessons, interactive board review style questions, and they offer free continuing education. The second current edition integrates the 2021 CDC STI treatment guidelines. This is the homepage of the National STD Curriculum. All visitors can access the entire website except for the self-study lessons, which require registration. Registered learners can track their progress and learn continuing education certificates or certificates of completion. The National STD Curriculum Center also hosts a podcast. Most podcasts are around 12 minutes long, and our clinical faculty from New York was recently interviewed about the clinical manifestations and counseling of patients in the current Mpox outbreak. You can navigate to this from the STD Curriculum website or again at the top right of the NNPTC homepage. We have even more resources for you. We are excited to announce the release of the CDC's STI Treatment Guide mobile app. Please take this time to use the QR code on your phone to download the app. This version of the app is more comprehensive. Each condition has been expanded to include more information from the guidelines about clinical care as it relates to diagnosis, management, and follow-up. It's more integrated. In addition to having more clinical care guidance, the app provides more information and resources to integrate sexual health histories into preventative care. It also has more features. The app offers easy access to clinical tools and clinical consultation resources, patient materials such as patient fact sheets, bookmark options, and screening recommendations. The STD Clinical Consultation Network is a free online system where clinicians can submit complex STI questions and an NNPTC experts from one of our PTCs will answer in 1 to 5 business days. The new STI Treatment Guidelines app links directly to this website to help clinicians in the management of STIs. We've also recently added Mpox as a category that we can give clinical consultation on. This is our nnptc.org homepage, and here is where you can navigate to STD-CCM from our homepage, as well as you can see the National STD Curriculum Center and their podcast. The NNPTC and the Public Health Institute at Denver Health collaborated on an 8-minute clinical education video to show step-by-step the process of intradermal vaccine administration of the Mpox vaccine. Our producer just dropped that link in the chat for you. You can also follow us on Twitter at NNPTC. Many of our infectious disease docs are also very active on there, and most topics are very clinical in nature. Now I'm going to turn it over to our first speaker, Dr. Nick Van Wagner.
Thank you so much, Destiny, and thank you to all of you for attending today. We're so happy to be here with you today. As we get started, I think it's always important to provide disclosures and acknowledgments as well. So our disclosures are listed here for Dr. Cheruby as well as myself, and also to give credit to the many individuals who have provided content for this. There are people all over the country who are seeing monkeypox and helping us document the outbreak in order to help each of us learn how to better diagnose and manage it. Next slide, please. So what we hope to accomplish today are really three things. First, we want to discuss the Mpox outbreak, both globally, very briefly, and in the United States. We then will focus on understanding the clinical presentation of Mpox. And finally, I will turn it over at that point to Dr. Cheruby, who will discuss treatment and prevention strategies for Mpox. Next slide. All right, so let's focus first on the 2022 Mpox outbreak. Next slide, please. So a little bit about the virus itself. Mpox is an orthopox virus, and it's in the same family as a few other viruses that you may be familiar with, certainly smallpox and molluscum contagiosum. They're in the same family. In fact, there are about 11 viruses in this family. Most of them, including Mpox, are zoonotic. In other words, they also infect animals, or they do infect animals, and that transmission can occur in some cases to humans. Now, Mpox was first discovered in 1958 in an outbreak of monkeys that were kept for research, and this is originally where it got its name, although there's no real other direct link, specific link to monkeys. And so we will refer to this as Mpox throughout the rest of this webinar. Now, the first human case was identified in 1970, and this was in the Democratic Republic of Congo. And we still don't completely understand where this virus lives outside of humans. Certainly African rodents and non-human primates have been known to harbor the virus and can transmit or infect in humans. Next slide, please. Now, we see two types of outbreaks. We certainly see outbreaks in areas where there has historically been Mpox, and we find it in the tropical rainforest regions of Central and West Africa. And most cases do arise sporadically and have typically occurred in the context of localized outbreaks. However, as we've moved forward, and in the past couple of years, as an example, we have seen it more frequently in these parts of the world where it has historically been identified. And you can see that this information comes from the WHO, but in 2018, there were almost 3,000 cases of monkeypox, suspected monkeypox reported, and in 2020, we were over 4,500. Next slide, please. Now, in the past, before this outbreak, we have seen Mpox also in areas where it has not historically been reported. And in those cases, typically the way the way it has occurred is through travel. So someone has either come in contact with an animal or a human with Mpox. They, while traveling, they then go back to a country where it has not historically been reported and have been able to transmit the virus to other individuals. Next slide. However, we're noticing something a little bit different in the 2022, or a lot different in the 2022 Mpox outbreak. And Destiny, I'll ask you if you will just go ahead and hit next slide a couple of times. That's going to bring up a couple of the animations. Thank you for that. 2 more times, please. So in this particular outbreak, what we noticed is that the first case was reported in early May, and this was a confirmed case in the UK, and it was from a patient returning from Nigeria. And Nigeria is a country where we have historically seen monkeypox, Mpox, excuse me. And so so it followed that sort of typical pattern. But then on May 12th, there were 2 new cases in the UK. And in this particular case, those individuals had no travel and no link to the index case. In May, Mpox was observed and reported in 4 other countries. And by June 5th, there were over 900 confirmed cases and in over 30 countries throughout the world. Next slide, please. And this is where we are as of yesterday at 5 p.m. Globally, Mpox cases were 70,420 and reported in 107 different countries. Next slide. You can also see from this particular graph the pattern of new cases over time. So what you are seeing by the small dots is the number of cases reported each day globally. You can see that in mid-August, the number of new cases reported was well over 1,000. Where we are as of October 4th is that the cases are declining worldwide, and we see less than 400 cases reported in the last few days. I would like to mention, though, that different countries and even different places, different states, different locations within the US are in different places as far as the evolution of this particular outbreak. So while we are seeing an overall decrease worldwide, and as I'll show you nationally, there are areas, and you may be in one of those areas where we are seeing actually increasing numbers or high numbers. We may all be in different places, in other words, in this. So next slide, please. So this is where we are as of yesterday in the US. A total of 26,311 cases have been reported. And what you're looking at in this graph, or this, excuse me, this representation of the US and the States is the number of cases. And so the way to interpret this is the darker the blue, the greater the number of cases. And so based upon where you are and where you're listening from, you can get an idea statewide the number of cases of Mpox that your state has seen. Particularly the 2 locations I would emphasize, California and New York, have seen very high levels of Mpox. Next slide. This graph is showing you the representation of cases reported daily. Those are the red or orange bars. The line is showing you the 7-day average. And similar to what we are observing in the globally, we are seeing that cases appear to peak in August, and we are seeing declines in the number of cases. While I am thrilled that we are seeing a decrease in the number of cases, I think this is a time when we need to be hypervigilant, and there's great value in this webinar and also in continuing to keep monkeypox on our differential in order to be able to diagnose, treat, prevent, and ultimately eradicate this particular outbreak. Next slide. So let's think for just a moment about where and in whom we are seeing this particular outbreak. Again, this is data from the CDC, and where we are seeing it is in younger people and predominantly males. You can see here that the highest number of cases in those 31 to 45, but it really is something we are seeing in men predominantly from the age of 21 really up until 45. Again, yes, anyone of any age, anyone of any sex, or anyone of any gender can get monkeypox, but this is the population, or the cisgender men is the population where we're seeing most cases. Next slide. And if we look by sexual behavior, we are seeing this predominantly among gay and bisexual men. As represented in this particular graph, what you're looking at in each bar is the percent. So 100% of cases of Mpox. And what you will observe, as designated by the blue and the orange color, is the percent is highest among gay and bisexual men. Next slide, please. We are also observing a transition in the distribution among race and ethnicity. And so each bar, again, is representing 100% of cases. And if you look at the different colors, the blue represents white, the gray is Hispanic Latino, and the purplish plum color is Black or African American. And what we are observing is that over time, the proportion of individuals who percent of people with monkeypox is moving more toward African American and Hispanic and Latino individuals. Evidence of that monkeypox represents where there are disparities in where we are seeing monkeypox. Next slide, please. And so to this point, I would like to summarize the largest. This is the largest Mpox outbreak in history. The majority of cases are in countries where Mpox has not historically been seen. I didn't make this point explicitly, but we are in the US leading in the number of cases, and we have been for a long time. And the majority of cases that we are observing are in men, in particular gay, bisexual, and other men who have sex with men. And now the greatest proportion of cases are reported in persons of color. Next slide. And next slide again. And so let's move on now to think a little bit about the clinical features of Mpox. And in order to do this, I'd like to talk a little bit about sort of the natural history of the infection. And I'll talk a little bit about the natural or the classic disease or infection, what we saw before this particular outbreak. And then I will contrast and talk about some of the specific differences and characteristics of what we are seeing in this outbreak. So there's an incubation period after a person is exposed to Mpox and they are infected before they start to show symptoms. Most incubation periods in most cases is around 7 to 14 days, but it can be anywhere from 5 to 21 days. This is a period where an individual has no symptoms and they are not contagious. This is followed by a prodrome, again, in that classic or traditional presentation of monkeypox. This will last anywhere from 1 to 4 days. People will have fevers. Next slide, please. They may have muscle aches. They may have chills. We do see lymph node swelling as well. And then toward the end, they begin to develop lesions in the at the head, in the mouth. During this period of time as well, they are viremic. This is followed by the development of a skin rash. Next slide, please. The skin rash usually lasts anywhere from 2 to 4 weeks. And as I mentioned, it starts in the mouth and then can spread to the face and extremities. It can include the palms and soles. Now, what I've given you here is some images of the evolution of the typical lesion of the rash. And I've given it to you with 2 different pigmented backgrounds so that you can see and characterize the similarities and the differences there. It usually starts as a macule or a color change on the skin that can last a few days. This is then followed by a raised papule or a raised skin manifestation. This evolves into a blister or a vesicle, which then evolves into a pustule. You will see that the pustule is typically present for a few days. This will eventually scab over and heal. The scab may last anywhere from typically lasts about 1 week. I want to come back for a second and mention a couple of things about the skin lesions. They are more deep-seated. They are more rubbery in nature. They are typically painful and start to itch as they move toward that healing phase. Next slide, please. In classic monkeypox outbreaks, what we have observed in the past is that all of the lesions associated with the rash are of similar size, and they're usually in the similar stage. So rather than having pustules, and crusts, they would all be pustules. They would all then evolve into crusts, as an example. I mentioned that they are painful. They become itchy as they move forward. The virus is in the skin, and the rash is infectious. And typically, individuals have anywhere from 10 to 150 Mpox lesions at a given time. Next slide. After that, there is recovery. And I do want to mention that in most cases, monkeypox is self-limited. Most individuals make a full recovery. Complications can occur in individuals who are immunocompromised. And the mortality rate in this particular outbreak of Mpox is low. And in fact, I believe worldwide, there were around 26 deaths reported when I looked last at the WHO site that I showed you earlier. Next slide, please. So let's talk about some notable differences in the clinical presentation. The prodrome, it may not be present in patients in this particular Mpox outbreak. Next slide. And so we don't see fever as often, or headache, or fatigue, or muscle aches. We do see swollen lymph nodes, and of course, we are seeing the skin rash. Next slide. Other notable differences is that we are observing that the lesions may be in different stages. We're observing high rates of genital and perianal lesions, and they may not disseminate to other parts of the body. A really critical point that I want to emphasize is that Mpox can mimic STIs and other infectious and non-infectious skin lesions. And so I'll say this a couple of times, but if we see someone and we're considering Mpox, we need to consider other STIs and other non-infectious causes. If we're considering other non-infectious causes, we also want to consider Mpox in our differential. Next slide, please. Another notable difference in the clinical presentation is proctitis. Proctitis, as a reminder, is inflammation of the distal part of the rectum. Symptoms include anorectal pain, tenesmus, or a sensation that you need to have a bowel movement, and rectal discharge. I'm showing you an image actually from a case report of an individual with Mpox that was reported early in this outbreak in the New England Journal of Medicine. And what this is an anoscopy. And what you're seeing is inflammation with shallow ulcerations and purulent exudate, which would be symptoms consistent with proctitis. Now, if this were the only thing that I saw, I would want to also consider other causes of proctitis. Again, we'll come back to that again. Another important message that I will say a couple of times is that we are also seeing Mpox in combination with other STIs. So if a patient comes in with Mpox, we definitely want to screen for other STIs. Next slide, please. And this is saying some of that, okay? So a couple of pieces of data from studies that have been published. And the first one was, again, early in the outbreak. And in this particular study, 1 in 4 individuals with Mpox had a concurrent STI. Again, emphasizing the importance and the value of screening for STIs in patients presenting with symptoms consistent with Mpox. As well, the CDC recently published a study in which they looked at individuals presenting with Mpox, and what they found is that individuals with HIV or a recent history of sexually transmitted infections were people who were commonly diagnosed with Mpox. In fact, 38% of individuals had HIV, 41% had an STI in the previous year, and together 61% had either HIV or STIs. And so offer HIV and STI screening for people who are being evaluated for Mpox. Next slide, please. And so in the very last few slides that I have, I would like to show you some examples of clinical manifestations. As we mentioned, there can be oral manifestations. Here you are seeing lesions in the back of the throat and on the tongue. If I were to have a patient come in with this, not only would I be interested in screening for and addressing Mpox, but also understanding the impact that this is having on ability to swallow, on ability to maintain PO intake. And Dr. Cherabi will talk a little bit more about treatment in his section. Next slide. Here are some examples of the lesions on different parts of the body. Again, deep-seated, rubbery in texture. And something that I didn't mention, but I will, is often they have an umbilicated center. Next slide, please. Here are some examples on the face as well as on the back of, it could resemble acne, it could resemble other things. So again, having a wide differential that includes Mpox is important. Next slide. In some cases, and in particular in individuals who are immunocompromised and some individuals who have underlying skin diseases, we can see disseminated disease. Here are examples of disseminated Mpox over the face as well as over the trunk. Next slide, please. And as we mentioned earlier, we are seeing both genital and perianal lesions, giving you some examples of individuals with one lesion all the way up to many lesions, to give you an idea of the spectrum of the disease manifestations we are observing. Next slide. We also are seeing that Mpox can mimic other types of STIs. And I bring up this example thanks to Dr. Reed. These are cases which really look like syphilis. And I would consider syphilis in these cases. Remember, syphilis is not always one chancre. It can be multiple chancres. It is not always painless. It can be painful. And so I would have considered syphilis in this, but also it's important to consider monkeypox since these are examples of monkeypox. Next slide, please. And so finally, just reminding you of the importance of considering other pieces in your differential diagnosis for Mpox. Certainly ulcerative STIs can appear like this, herpes simplex, syphilis being the most common that we might see. If you see a diffuse rash, certainly there are causes that are both STI related as well as other types of infections. And finally, with proctitis, we also want to consider the other common causes and test for those. Next slide. And in these next slides, what I'm giving you, and happy to make these available to you, are examples of presentations of herpes simplex virus, syphilis, as well as LGV, granuloma inguinale, and chancroid, where there can be overlap in the manifestations with monkeypox. Next slide. This is demonstrating some of the diffuse rash that you might see associated with syphilis. Next slide. Here are some examples of rashes associated with varicella, with molluscum, cryptococcal, as well as disseminated gonorrheal infection. Next slide, please. And then proctitis. Again, remember, for an individual with proctitis, chlamydia, including the serovirus for LGV, gonorrhea, HSV, syphilis, and now Mpox must be considered. Next slide. So this is a summary slide just to remind you that we are seeing atypical presentations of Mpox, both related to prodrome, to the rash appearance, as well as rash stages. The rash location, we're seeing genital and perianal lesions frequently, and that there are other symptoms, including proctitis, and we are seeing co-infections with other STIs. Next slide. And so I know I went relatively quickly through a lot of information. There's a lot to share today, and I want to thank you for your time, and I'll turn it over to Dr. Cheruby. Thanks so much.
Thank you so much, Dr. Van Wagner. So I will be taking over and discussing transmission. Next slide, please. So transmission, as Dr. Van Wagner just shared, is most commonly occurs during the symptomatic phase in which a patient actually has active lesions. And so you can see here on this table that during the incubation period, it is presumed that individuals are not necessarily contagious and want to monitor for symptoms. The prodrome, an individual may be possibly contagious. However, once again, it is very difficult to distinguish prodromes from other disease processes. So it's quite hard to see if a person does have active Mpox, for example, but we know that individuals with a rash do have the highest amounts of viral load, as well as are contagious at that point. And during that time period, they should isolate at home, especially if they have active lesions. And mind you, this is an isolation of around 2 to 4 weeks until those lesions crust over and you get a new layer of skin, which can be quite a long time for some people. So while this disease process may not carry a high morbidity, a high mortality, it definitely does carry a high morbidity. And so it is important to recognize that in our patients. Most commonly, transmission is through direct contact with bodily fluids, scabs, and skin lesions, including transmission by sexual contact, which is what is occurring in the vast majority of cases in this current Mpox outbreak. There have been known to be transmission via fomites, such as objects or fabrics. We also know that clothing or things with weaving can carry Mpox virus for a longer period of time. So it's important, if there is any kind of laundry or clothing that has Mpox on it, not to shake it and to try to actually launder it separate from other laundry in the house in a shared household. And then respiratory secretions can be infectious with very close face-to-face contact. But I want to emphasize this. Mpox itself is quite a heavy virus, and it actually requires droplets in order to be able to transmit. And it requires prolonged face-to-face close contact. So we actually haven't been seeing much in terms of respiratory transmission during this current outbreak, with the vast majority of cases being direct contact to lesions. So I do want to emphasize that there is no reported airborne transmission, and no transmission that we have seen, for example, on airplanes and other methods of transmission that we typically would associate with, example, for COVID-19. Next slide, please. So a little bit about sexual transmission. Next slide. So this has become a little bit of a debate conversation, and I want to do away with a lot of the debate and hubbub about this, because ultimately what I can say is that with confidence, the majority of cases in this current outbreak have occurred through close sexual contact. Actually, in the New England Journal of Medicine, they did a review of over 500 cases in over 16 countries, and sexual transmission was suspected to be in 95% of cases. 99% of US cases from May to July 2022 occurred among cisgender men, almost all of whom, 94%, reported a recent sexual intimate contact with other cisgender men. Lesions in the anal or genital region are actually more frequent. As Dr. Van Wagner actually just mentioned, this is actually quite atypical for Mpox outbreaks. Previous Mpox outbreaks actually involved lesions starting on the hands centrally and then moving centrifugally. This is not what we are currently seeing, where the majority of the lesions this time are actually occurring in the anal genital region. And it would only make sense that this is in line with the sexual contact that we are seeing in this current Mpox outbreak. We just mentioned that co-infections with other STIs are quite common in this current outbreak. And then other STIs, we need to remember, such as herpes and syphilis, can be transmitted sexually, but also less commonly non-sexually. And so this idea of trying to fit something into a label kind of defeats the purpose of infectious diseases, right? Infectious diseases, there is no black and white. There are many different ways in which certain disease process can be transmitted. And in this current outbreak, the majority of cases have been spread through sexual transmission. But historically, this hasn't necessarily been the case. And so it's important to recognize the nuances here. But I do want to highlight, though, there's a recent study from The Lancet that was released that showed that there are higher viral detection in skin lesions, anal lesions, and throat lesions than from blood, urine, or semen. And the highest viral loads were on skin lesions and anal samples, which again makes sense with the current transmission that we are seeing in this current Mpox outbreak. Next slide, please. So let's talk a little bit about personal protective equipment, or the precautions that are being recommended for healthcare workers specifically, and a little bit more about how healthcare workers can take samples for Mpox. And so what is being recommended is a little bit of a conservative approach, but it is that individuals will wear a gown, glove, eye protection, and an N95 respirator in order to, in healthcare settings, when sampling Mpox samples. Next slide, please. But I do want to emphasize this: with proper PPE use, spread to healthcare workers is extremely rare. There was this MMWR that was released that showed that that spoke about healthcare worker exposures in Colorado, where 313 healthcare workers were exposed to Mpox with low use of recommended PPE. Overall, 23% used the recommended PPE. 12% of individuals received post-exposure exposure prophylaxis vaccination with a Chinios vaccine. And all individuals were monitored for a total of 21 days. Of all of those individuals, not one of them acquired clinical Mpox, which further highlight the idea that Mpox itself, that with proper PPE use, it is unlikely that healthcare workers would acquire Mpox. There was one case of transmission through healthcare workers from a needle stick with a lesion appearing 5 days later. And per the WHO, if you look at their website and their representation of the global epidemiology, there are 421 cases reported amongst healthcare personnel. However, they do make note that the majority of these cases, individuals who did end up having clinical Mpox obtained it from the community and not from healthcare settings. And so there's further investigation being done, whether these are via occupational exposures or from the community itself, with more data being needed. Next slide, please. So let's talk a little bit about diagnosis, treatment, and prevention. So for diagnostic testing, the go-to test, your gold standard, is going to be an orthopox virus or Mpox virus PCR. We have a testing capacity of around 80,000 tests per week. And when you want to swab for Mpox, it is important. And people who have been in my clinic will have heard me say this many, many times before. You want to vigorously swab those lesions for around 5 seconds. It is okay to sample multiple sites from the same swab, but typically what we're recommending is 2 swabs per lesion from at least 2 lesions. It is really, and I want to highlight this, it is important to do a thorough skin examination throughout the whole body, because individuals may have certain lesions that might not be visible. And so the more sampling that you can get and the more lesions you can sample, the better likelihood you are to be able to detect Mpox. The reason for that vigorous swabbing is because you need to be able to detect human DNA as the control sample for the PCR test. So if your test comes back inconclusive, it means you didn't swab vigorously enough. There's no need to unroof the lesions, and what you'll want to place is in a dry tube, but some different tests might require viral testing media or an Aptima tube. Rectal swabs from Proctitis have been used in the past and have detected Mpox as well. But again, if a person has if, for example, we have had reports of certain labs not feeling comfortable doing a swab from a rectal lesion, then you want to do a thorough skin examination to find another lesion within the body. And then typical turnaround time is around 1 to 5 days. And so that is pretty decent, but sometimes it may be up to 6 days to a week. Next slide, please. For symptomatic management, it is really important to assess the pain of the patients and to take the pain of our patients very seriously. So amongst a multinational collaborative of around describing 528 Mpox lesions, mucosal lesions were found in up to 40 patients with severe pain, often out of proportion to exam. I must highlight here that a lot of these lesions are in anal genital regions, which are extremely sensitive. So please, please, please pay attention to that. 13% of patients were actually admitted to the hospital, and 30% of that was for pain management. Other complications can occur as well, such as a secondary bacterial infection, and rarely you could get perineal abscess and rectal perforations. I can say from our hospital setting, we have actually had 2 cases of individuals who had such severe proctitis that they were concerned for things like lymphoma and they had such swollen lymph nodes. So please, 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 if an individual does have proctitis, please take this serious and consider Mpox within your differential, as Dr. Van Wagner had highlighted. Next slide, please. Within the line of symptomatic management, it is recommended to use NSAIDs or acetaminophen, and you can also use topical steroids and topical lidocaine, but please use topical lidocaine with caution with broken skin. Apply topicals with gloves, and please dispose of gloves if you are not the patient who is actively infected. If the patient can provide those creams themselves, and that would be helpful. In extreme cases, you can use gabapentin and opioids, as well as stool softeners in individuals with proctitis to decrease straining in that region, and warm sitz baths, which it is important once again to drain and disinfect after use. Next slide, please. So what about treatment itself? For treatment, we have an option here, which is Takeover Mat or Tpox, which inhibits the VP37 protein. This is an orthopox virus-specific protein, and Takeover Mat actually was originally designed for use for treatment for smallpox, which we said was a related virus. The dosing is 600 milligrams orally twice a day for 14 days. I have to highlight here, though, that it is important to take with a very fatty meal. You want at least 600 calories or 25 grams of fat in order to help aid absorption. And then again, we have to assess for individuals' ability to swallow, because if a person has an oropharyngeal lesion, then that might inhibit their ability to be able to swallow this medication, in which case an IV formulation is available. For IV formulations, renal dosing is available, and it is important to note drug-drug interactions. The ones noted by the CDC are a decrease in the effectiveness of midazolam, as well as repaglinide can cause some hypoglycemia in use with Takeover Mat. There had been, I do want to note, some hypothesized interactions with certain antiretroviral therapy drugs for HIV. However, these are not noted on the CDC website, and so I just want to highlight here that this is something that is actively being looked into in case you have heard about it, but thus far we haven't been seeing much in terms of interaction with HIV antiretroviral therapy medications. Next slide, please. When to consider treatment, it is important, of course, to consider it in severe disease such as hemorrhagic disease, a large number of lesions that can become confluent with one another and can disseminate, as we saw in the previous pictures. Sepsis, encephalitis, as well as ocular periorbital infections. And it is important to remember, please, in patients who do have lesions on their hands, not to touch their eyes, because it can spread to their eyes and cause ocular manifestations of disease. Also of note, in the majority of individuals who meet the indications for treatment are in the second category, in which they have involvement of anatomic areas that might have serious sequelae or that involves scarring or strictures. So individuals who have lesions in the pharynx, foreskin, vulva, vagina, urethra, or rectum, it is important to consider these individuals for treatment. And people who are at high risk of severe disease, such as immunocompromised individuals, pediatric populations, pregnant or breastfeeding individuals, and individuals who have conditions affecting skin integrity. Next slide, please. Of note, there have been some severe complications, including encephalitis, with 2 cases reported in the United States, occurring 5 to 9 days after symptoms. The manifestation itself was as acute disseminated encephalomyelitis with respect to the clinical and radiographic features. However, interestingly, there is no evidence of Mpox virus neuroinvasion with no virus detected in the CNF. In cases of encephalitis, you would really want to make sure that to use Takeover Mat. However, of note, CNS penetration is still unknown. We're still learning a lot about Takeover Mat and its relative use. Next slide, please. So how to obtain Takeover Mat? It is available through the the Strategic National Stockpile under an expanded access investigational new drug protocol. The treatment can begin upon receipt of medication after obtaining informed consent. So you can see the necessary forms highlighted and underlined below. You would want the FDA form 1572, that's 1 per institution or facility. You would want an informed consent, and that needs to be physically signed by the individual themselves before we can allow them to take the medication. And you would go over things like the side effects and the certain requirements to take the medication along with that informed consent. And then a patient intake form is required within 7 days of an individual to be turned into the CDC within 7 days of an individual starting Mpox. The forms of note can be returned to the CDC after treatment begins, and this should not delay treatment. We know antivirals work better the earlier you take them. And again, patients are in pain. We want to get them treatment as soon as possible. And of note, empiric treatment can be started in cases where there is high suspicion with pending test results. So you don't have to wait for a confirmatory test in order to be able to start treatment. So I really want to highlight that. Optional forms include a patient diary, clinical outcome forms, as well as photos, lesion samples, and measurement of the pharmacokinetics of Takeover Mat if that is obtained in your laboratory. Next slide, please. So additional considerations of when to use Mpox. We really need to highlight the fact that we still don't have a lot of data of Takeover Mat within humans, but not only that, within humans that are with Mpox itself. So the lack of Takeover Mat effectiveness data to date in people with Mpox is still an important fact, and we're still gaining more information. The lack of data indicating which patients may benefit most from Takeover Mat is still a huge area to consider. And then the concern for development of resistance to Takeover Mat, which could render the drug ineffective for treating patients, which I'll speak to on the next slide. Next slide. The slide after this one. So of note, Takeover Mat is safe. This is actually an MMWR report that showed that 93% of individuals who received TPOXX did so in an outpatient setting. 59.6% recovered without sequelae, with 12.9% having sequelae. Days to improvement, the median days to improvement was 3 days, with no adverse events in 96.5% of people. The most common adverse events that were noted were headache, some nausea, vomiting, and there was only one severe adverse event that required hospitalization. Next slide, please. But with respect to TPOXX allocation, we know that we are changing in with the landscape in which Mpox is affecting certain populations is ever shifting. Right now, we are seeing an increase in the amount of cases amongst Black MSM as well as Latino MSM. And so with that, we want to make sure that individuals who are receiving Takeover Mat are of the populations that are most being affected. And right now, the majority of Takeover Mat is still being given to white individuals, and we're still seeing a disparity persist. And these are disparities that persist across STIs in sexual health in general, because to the right, you can also see that it is representing HIV, new HIV diagnosis. And you can see, again, the vast majority of new HIV diagnoses are amongst Black and Latino MSM. And so these disparities you'll see time and time again with respect to STIs, and we really need to make sure that we are giving our resources to the individuals who are most being affected by this disease process and not neglecting any certain patient population. Next slide, please. And then this is just showing the amount of the cumulative number of TPOXX prescribed patients reported to the CDC. And again, the majority of individuals receiving TPOXX are white individuals, followed by Hispanic, and then Black individuals. And then the majority follows the same basically curve that we are seeing in the individuals who are being affected by Mpox, with a total of over 3,600 patients being treated with TPOXX to date. Next slide, please. I do want to highlight of note, though, there is an active clinical trial that is being done on TPOXX for use in Mpox. It is called the STOMP trial, and individuals who don't necessarily meet the treatment requirements for TPOXX that was listed earlier, all individuals with Mpox can qualify to a certain extent within this clinical trial. So this is also, if you do have a clinical trials unit within your own university academic setting or within your region, it may be useful as a resource to get individuals access to TPOXX who may not meet qualifications for and indications for TPOXX otherwise. Next slide, please. And so, we finally got to the resistance slide. Wonderful. So with respect to resistance in vitro, there are multiple single amino acid substitutions associated with resistance to TPOXX. And in some mutations, there may be a loss of efficacy in vivo as per animal models. So it is important to counsel patients to take the medication as prescribed and to complete their course, even if their symptoms happen to resolve before their treatment course is complete. Next slide, please. Other treatments of note, cidofovir, brimcidofovir, and vaccinia immunoglobulin IV have been suggested as possible other treatments, but of note, cidofovir is associated with nephrotoxicity, which might not make it a very good option for individuals. Brimcidofovir currently is not available through the Strategic National Stockpile, and Vaccinia immunoglobulin has been licensed for the treatment of complications from Vaccinia vaccine, and the CDC holds expanded access protocols that allows it for use with orthopox viruses in an outbreak. However, there is currently no efficacy data. Next slide, please. So let's talk a little bit about immunization. Currently, the vaccine that we are using is the Jynneos vaccine. That is a live non-replicating virus. It is a 2-dose vaccine dosed 28 days apart. It is considered protective at its maximum protection 2 weeks after the second dose. There actually was a recent study that was released that the majority of individuals who had developed Mpox after getting vaccinated actually developed it after within 2 weeks of that initial vaccination, the first dose. And so just a reminder to your patients, you have maximum protection 2 weeks after your second dose. Mostly, it is a well-tolerated vaccine with a local side effect, which is pain and itching at the injection site, especially when giving intradermally, which we'll get to in a second. And it is okay to give in pregnancy in immunosuppressed individuals. However, there is a question as to efficacy versus intradermal dosing amongst HIV and immunocompromised or immunosuppressed individuals who may benefit from a subcutaneous dosing as opposed to an intradermal dosing. The other historical vaccine that has been used is the ACAM2000. However, this is a live replication competent vaccinia virus. This is the traditional smallpox vaccine that any person that you ask if you've been vaccinated against smallpox and they say, yeah, I think I had the scar on my shoulder. This is from the ACAM2000. It is important to note that the virus can spread to other parts of the body with the ACAM2000, and individuals can get what is known as vaccinia. And so this is why currently Jynneos vaccine is the currently used vaccine. Next slide, please. And there's a picture. Next slide. So again, currently we are utilizing an intradermal dosing administration, and that has been approved for this vaccine. In order for us to use actually 1/5 of the dose that would be used in subcutaneous dosing, and that allows us to vaccinate a lot more individuals, which is fantastic. There's been one study that was done in 2015 that showed that there was an equivalent antibody response between intradermal and subcutaneous dosing. But again, more information is being obtained every day with respect to the effectiveness of intradermal dosing. I will highlight, though, my patients always remind me the intradermal vaccine is much itchier than the subcutaneous vaccine. So it is really important to inform your patients that they might have an itchy spot, and that is normal. Next slide, please. And so you could see here, these are the different development of the vaccination site with different skin tones after injection. And so it is, again, very normal for people to develop a little bit of an immune response, as one might say, at the intradermal site. Next slide. So again, the preferred dosing vaccination is around 0.1 milliliters intradermally as 2 doses, 28 days apart. For individuals who, however, may have a history of myocarditis or have a history of skin conditions, including keloid development, you would want to use that subcutaneous dosing. The current vaccination strategies have developed from post-exposure prophylaxis to PEP++ to PrEP. So post-exposure prophylaxis was for individuals who had a direct exposure to Mpox to be given within 4 to 14 days after exposure. And that was known to decrease likelihood of them developing Mpox, but also if it was after, if it was towards the later end of those 4 to 14 days, then it could decrease the severity of disease progression. However, it is not recommended to give Mpox to give the Jynneos vaccine if a person does have active Mpox lesions. PEP++ was for those with certain risk factors of possible or presumed exposure based off of recent experiences, including individuals who are MSM or transgender, individuals who have had, it's left, y'all, I promise I'm going to stop yammering, but This is a number of total vaccine doses given, and you can see the dark blue is actually the first dose, followed by the light blue, which is the second dose given. We are moving more towards a pre-exposure prophylaxis vaccination strategy. We have actually moved towards that in Missouri and St. Louis as of yesterday, which is very exciting, in which we want to see individuals who are at an increased likelihood of acquiring Mpox virus have access to the vaccine if they didn't meet qualifications before. Again, previously it was for PEP++, they had to have 2 or more sexual partners within the last 2 weeks, or a history of going to a sex on-premise venue, for example, or a place where having had sex where in a location where there was a known Mpox outbreak. Now you need to have 2 or more sexual partners within the last 6 months, or be an individual with a history of bacterial STI. And so this has greatly increased access to a lot of individuals who may have an increased likelihood of acquiring Mpox. But again, it is important to highlight here, look here to the right, the vast majority of the vaccine uptake has been amongst white non-Hispanic individuals, followed by Hispanic and then Black individuals. And so it is interesting with that shifting dynamic in which we are seeing an increased amount of cases amongst Black and Hispanic individuals, and we're seeing a decrease in the proportion among cases of white individuals. This may be a reflection of the fact that actually there has been the highest uptake amongst white individuals of vaccination. And we really, once again, need to meet our patients where they are at in their communities with trusted community messengers in order to make sure that we are getting the message across that we really want to try to protect individuals from a disease that can cause quite a bit of painful lesions for quite some time. Next slide, please. Now, how effective is Mpox vaccine? Again, I said we're still getting a lot of data about this, but this is data from the CDC that was recently released from the Genius vaccination. And it actually showed that individuals who are unvaccinated are 14 times more likely to develop Mpox compared to individuals who have received a full dose of, or a first dose, sorry, of Mpox vaccination, which is very exciting news, but again, more data to come. Next slide, please. And this is just from the CDC itself, emphasizing vaccine equity. And like I said, we really, really have to work hard in order to make sure that we are meeting patients where they are at, regardless of their education, income, wealth gaps, job access, racism, homophobia, and other discrimination, and gaps in healthcare access, as well as transportation and neighborhood conditions. And we must acknowledge the fact that historically, a lot of these populations, Black, Hispanic, Latino, LGBTQIA+ individuals have oftentimes been the subject of stigma and discrimination from the healthcare systems themselves. And so it is really important for us as healthcare community to counteract that and to do our part. It is our obligation, not our patient's obligation, in order to counteract that and make sure that we are being equitable in terms of our vaccine distribution, as well as our testing and treatment distribution. Next slide, please. This is also with respect to, it's a multi-pronged approach to prevention. And so behavior change has played a big role with respect to decreasing the acquisition and stemming the tide of this Mpox outbreak, with individuals reporting. This was a study done on men who have sex with men since they learned about the Mpox outbreak. And a survey showed that the number of individuals who had a decrease in one-time sexual encounters was 49.8%, so around 50%. Sex with a partner met on a dating app or in a sex venue also decreased by around 50%. Having group sex, 50%. Going to sex venues or events, 40%. And going to social events with close contact or dance party or raves decreased by 35%, whereas condom use remained constant. So again, this is just to show that there has been a behavior change to try to decrease this. But again, behavior change is only a Band-Aid. We really need to get to the major, we need to get people vaccinated, because behavior change will change back again, and individuals will be having sex as we hope is within their sexual health goals. And so we really want to allow people to have the sex lives they want to have while not having to worry about this disease outbreak. Next slide, please. And so my last point is I do want to address stigma with respect to Mpox. So it is important to note, while anyone can get Mpox, gay, bisexual men who have sex with men represent the overwhelming majority of cases. And as I said just on the last slide, it is really important to recognize that LGBTQIA+ individuals have experienced stigma and discrimination at the hands of the healthcare system for years. And that stigma and discrimination is only worse when you look at individuals of color. And so 9% of lesbian, gay, and bisexual individuals reported a doctor refusing to see them because of their sexual orientation. And that goes up to 29% of trans individuals reporting a doctor refusing to see them because of their gender identity. So we have to acknowledge this. We have to acknowledge the fact that there is a large amount of stigma amongst this community, and Mpox has only allowed a larger proportion of stigma. It has a heightened stigma against this community, seeing as they were the individuals most affected. But I do want to say that this community has done a wonderful job of being engaged from the get-go, organizing vaccine events, doing behavior changes as a community, making sure that they are spreading information with respect to all the developments with respect to Mpox. And this is because of years of shared trauma with respect to the HIV epidemic and other STIs as well. And so what is needed is trusted community messengers. People can't get to the message if they can't get past the messenger. And so it is really important for us to remember that we need community messengers who are trusted, who, if they convey a message, will allow community members to be seen but not judged. And we always have to remind ourselves that there's no such thing as a quote unquote gay disease. A virus itself is, it affects individuals regardless of their sexual orientation or gender identity. Ultimately, what leads and stems, what fuels stigma is fear. And so when people are scared, they tend to propagate stigma. So how can we as healthcare providers try to counteract this? We need to focus on the facts and make sure to not add moral judgment in our communications. It is okay to acknowledge that the majority of cases have occurred amongst gay and bisexual men who have sex with men, while in the same breath saying that because of that, we really need to allocate our limited resources towards this community that is being most affected and do our part as a healthcare community. We need to use inclusive language and recognize that PPE and paperwork sometimes can serve as barriers. If you're walking in with giant PPE, people feel like a diseased individual. And so it is really important to try to counteract that and make people feel as comfortable as possible. And recognizing that isolation for 2 to 4 weeks and asking them to do so is very challenging. So please be cognizant of this and try to work with your patients on individualized patient care. All in all, though, we really must do better too. And what we have learned from this whole outbreak is that we really must work on normalizing sexual health as well as STI screening as a whole. And so I just want to end on that note. And next slide. I think there are no more slides. Wonderful. And we can go to the Q&A section.
Thank you so much for that wonderful presentation, both of you. We are going to stay a little longer. For anyone who's available and has a question, feel free to enter it into the question and answer, and we can respond to you as quickly as possible. We've already answered the 2 questions that were in here. I'll give you all a minute.
I think there was
While we're waiting. Oh, sorry, do you see one?
Right. Alana, there was a question with respect to the chat, actually.
Oh, it's in the chat. Okay.
Yeah, and so this was any thoughts on expansion of the Genius vaccine to PrEP eligibility? Is supply adequate? And so what I will say is that our supply has increased a lot because of the use of intradermal vaccination, which has been fantastic. And we have been seeing a slight decrease in demand. At least I can speak for in St. Louis, where I function. There's been a decrease in demand. Now, part of that is, of course, making sure that we are going to the communities that might be most affected and actually reaching communities that haven't been reached yet, which again is a very, very important thing that we have to work hard on as a healthcare community. But also we do know that we do have enough vaccine doses to be able to supply at this point. And so there is, I feel like I want to increase access and I want to increase the amount of individuals who have been vaccinated as much as possible. And including individuals who, we have to remember, the PEP was like if you've had sex with partners within the last 2 weeks. One of the caveats of that is we've seen behavior changes. People have decreased the amount of sexual partners they've actually had because of Mpox. So actually, this might allow us to vaccinate individuals who didn't meet those more stringent criteria and may allow them to feel a little bit more comfortable having sexual partners again, getting out there and meeting their sexual health goals. Dr. Van Wagner, do you have anything else to add?
No, I think that was a great answer. I would like to ask Dr. Ahmed, Dr. Lee, if they have anything to add. We've got some experts from the CDC here. Anything that you would like to add about that? You may be muted, Dr. Ahmed.
Yeah. Dr. Ahmed is here on behalf of our vaccine task force, so I'll let him go first.
Thank you. I think first and foremost, I thank you very much for the floor. The amendment in the PrEP Act from 2016 was for several reasons, and one of the major one was to broaden the list of providers that can administer medical countermeasures, including monkeypox vaccine, and requires these providers to be trained. And the other important reason was to provide liability immunity resulting from the administration or use of the countermeasures. Having said that, I think that also has important implication in terms of people eligible for pre-exposure prophylaxis. I think the most important being that people can self-attest without going through the whole list of eligibility criteria or criterion. People can self-attest, and I think that is a very important step forward in terms of access to vaccine for all folks, especially from health equity perspective, that people can self-attest that they meet one or more of the criteria mentioned there in the interim clinical considerations, and they do not need to be verified for any purposes. If they self-attest, that's enough for them to get access to vaccine. And I think having broadened the list of providers, especially the independent pharmacies, would be an important step.
So I will add to this that this is the eligibility for PrEP for Jynneos is under active discussion, and is something that we hope to bring to ACIP in the near future. We are having more and more supply of vaccines, so this looks good. But however, we have obviously less than 365 million, so we need to expand this somehow. But as to where to draw the line, we're taking into consideration mathematical modeling, equity, et cetera, et cetera. So stay tuned.
Thank you so much for that feedback. We do have other questions in the Q&A. The first is, can you briefly review forms and processes for prescribing medication? Dr. Cherby, did you want to cover that?
Yeah, so what's lucky for everyone is the CDC website goes through a step-by-step process actually of how to obtain Takeover Mat, and it is very straight. I won't say it's straightforward. I will just say that it does require a little bit of time, but it is quite, the instructions are very clear in order how to obtain it. And so, whereas previously they have actually shortened, we had more forms previously, now they've actually shortened the amount of forms, and they've increased the amount of time that is allowed to give these forms back. So the major thing that you have to get is, of course, that FDA form for your institution, if you have not yet done that. And then an informed consent for the patient. The medication itself cannot be given to the patient until that informed consent is signed. And then after that, you could do the patient intake form. But the majority of the patient intake form is actually based off of the last evaluation of the patient. And so you can actually use information from the evaluation of the patient themselves in order to fill out that form. And it's not as again, it requires a little bit of time. I'm not going to lie to people, but it is not as time intensive as it was previously. Would you agree, Dr. Van Wagner?
Absolutely.
We're in terms of the medications we're working on for Takeover Mat, and also all these things actually we're working on electronic form that will hopefully make life a little bit It
easier.
won't make the number feels fewer, but it'll make it less faxy and papery. So that hopefully that will make everyone's lives a little bit easier. The thing I also want to highlight is that, Takeover Mat, it's one of the available medications, but for patients with, profound immunosuppression, we urge people to consider additional medications such as Cidofovir, which you don't need us for, and also Vaccinia IgIV, which you can reach out to us for, and then we will have a short call and then ask you for some addresses and then get this to your hospital.
And we did supply the link in the chat with access to the step-by-step process on how to obtain Takeover Mat and the process with all the forms that are linked to that website. There is another question. It says, so is it considered safe for pregnant women? I think that was directed to the vaccine, but if you have comments on the Takeover Mat as well, that would be great to add in there.
So I can start to answer that question a little bit, if that's okay. So, we really don't have a lot of data to really guide administration of the vaccine in both pregnant people as well as breastfeeding people. But because this is a non-replicating virus, theoretically, it should not have an impact there. And so really, this is a question of shared decision making with the patient, discussing the pros and cons of giving the vaccine and making that decision together. From my perspective, and again, if you go to the CDC website, there's guidance on this. They're always updating that guidance as new information becomes available. But it should be offered to people who are pregnant, or can be offered to people who are pregnant or breastfeeding. Dr. Ahmed, anything to add to that?
Accurate, and there is no evidence of any harm in that situation.
Okay, and I think with that, we've answered all our questions that were in the Q&A as well as in the chat. So Destiny, I'll hand it back over to you.
Thank you so much. I really appreciate it. I want to give a big thank you to our presenters as well as our CDC guest. We have one more Mpox webinar, and that will be on November the 7th. I am posting the registration in the chat, so you can come to that one as well. We will have different faculty on at that time, and who knows, things may have changed by then as well. So thank you so much for joining us today, and reach out to your regional PTC if you need training or technical assistance on Mpox. Thank you.